Good morning. My name is David Adeyemi, and I work with the Clinton Health Access Initiative on the innovative group antenatal care deployment in Kano State of Nigeria. I'll be taking you through the presentation on applying responsive feedback to improve the enrollment of pregnant women into the group antenatal care cohorts in Kano. The group antenatal care approach, which I will refer to as G-ANC, is an alternative service delivery model which integrates all pregnancy-related health assessments to a group of pregnant women of similar gestational age to improve the overall uptake and quality of reproductive, maternal, newborn, child, adolescent health and nutrition services. For a bit of context, in Nigeria, antenatal care uptake is poor. However, from the successes and impact demonstrated by the GNC, this approach provides a platform to promote the uptake and quality of ANC and key RMNCH interventions along the continuum of pregnancy, delivery, postnatal, and childhood care, where primary healthcare services are provided. Taking data from the 2018 National Demography and Health Survey, Kano has about 51% of pregnant women who attended the nationally recommended 4 antenatal visits, compared to national average of 57%. However, about 22% deliver at a facility taken by a skilled attendant, while 22% of mothers received postnatal services. 34% of pregnant women also received at least 2 doses of intermittent preventive treatment for malaria in pregnancy. The Kano State Government, through the State Primary Healthcare Management Board, is implementing and providing oversight in the G-ANC model deployment in 484 Apex health facilities spread across all the 44 LGAs to improve the utilization and provision of quality ANC and other reproductive maternal newborn child health services in the state. In support to the state to adopt and implement the G-ANC model, CHAI is providing the needed technical assistance to the State Primary Healthcare Board to sustain the model as part of their primary healthcare service delivery and systems. The project utilized the responsive feedback process to reflect on key learnings and use evidence to prefer and implement adaptations to improve outcomes. To define the process to continually assess implementation and provide insight into program improvement, a stakeholder meeting was convened at the inception of the deployment to enhance ownership and identify feedback processes such as periodic mentoring and engagement with beneficiaries through the client exit interviews to inform adaptations. Following the initial phase of implementation, the processes established revealed and observed low enrollment of pregnant women into G-ANC cohorts. This prompted a review of the approach by key stakeholders, such as the government personnel at the state, local government level, and service providers, and the community, to deliberate on how the predefined criteria restricts the enrollment of pregnant women and limits the coverage of RMNCH counseling. The predefined recruitment criteria for GNC only allows pregnant women between gestational age of 16 to 20 weeks to be enrolled into cohorts. The evidence generated guided the modifications to the implementation approach. In addition to the limitation caused by the pre-designed enrollment criteria, the coverage of pregnant women that received counseling for essential RMNCH services were below optimal due to the structured counseling method of one topic per ANC visit. Also, from the desk reviews of facility data, about 3/4 of pregnant women who register for antenatal care are above 20 weeks gestation. And though there is high demand by this category of women, they are exempted from being enrolled into GNC. Collaboratively, the key stakeholders modified the recruitment criteria for the formation of G-ANC cohorts and the counseling method for RMNCH services. Specifically, the adaptations proposed and subsequently endorsed include the removal of gestational age limits from the enrollment eligibility criteria to create opportunities for participation of all pregnant women, to strengthen ownership and inclusiveness. There was also the introduction of an abridged RMNCH messaging that covers the full spectrum of topics discussed during ANC visits 1 to 8 for facilitation at each and every session before an in-depth counseling on one RMNCH topic is done. This was done to cover for missed attendance and address any knowledge gaps. The graphic chart below illustrates the processes taken from pre-modification to modification and post-modification phases. Now, looking at the results following the modifications applied to improve G-ANC outcomes, there has been a progressive increase in recruitment of pregnant women into G-ANC and transition from traditional ANC to G-ANC across activated facilities. Also, as a result of the modification on the counseling approach, there is an increase in the coverage of pregnant women counseled on essential RMNCH services, with resultant increase in facility delivery and postnatal clinic visits. Although there are significant results following the modification of G-ANC approach, a few challenges were observed, one of which was the difficulty for high volume facilities to conduct multiple G-ANC sessions concurrently due to human resource for health challenges. This was mitigated by assigning flexible schedules for different cohorts. For example, a cohort can agree to meet at a certain time of the day, while another group take another time slot to hold their meeting, and this arrangement is made with the G-ANC providers. There are several lessons learned from the modification of the G-ANC approach, but one important lesson was that due to the adaptations that were guided by the responsive feedback processes, all pregnant women, irrespective of their gestational age, had the opportunity to benefit from the G-ANC and other ancillary RMNCH services. To sustain the gains achieved, the State Primary Healthcare Management Board has integrated the modified G-ANC approach into existing policy, such as the Annual Operational Plan. The state has also identified existing state funding streams to support continuous on-the-job learning and mentoring exercises across facilities and for improving facility utilization. On behalf of the entire team, I want to thank you for listening.